Evening, good morning. The meeting is indeed being recorded. You probably just got the message. My name is Jennifer Crow. I work at the Universidad Nacional in Costa Rica at the Institute IRET with the program SALTRA, Work, Health, and Environment in Central America. And on behalf of the CENCAM board, we're very, very happy to have you all participating tonight or this morning, as the case may be. For those of you that are new to CENCAM, CENCAM is the consortium on the epidemic of nephropathy in Central America and Mexico, and was started in 2012, and represents a group of about 130 researchers from about 15 different countries working in different disciplines related to CKDu. And our mission is to contribute to knowledge generation and promote and facilitate activities and policies to reduce CKDu occurrence in Central America, Mexico, and now in other parts of the world. Right now, our board, which is an elected group of people from different countries that represent the other members of CENCAM, is working in subcommittees. And one of the subcommittees is a visibility subcommittee that has really made an effort to try and increase efforts to make CENCAM more visible, and also to engage other folks that are working in different parts of the country. And in this case, also with the clinical subcommittee in this particular topic, and also with the topic of our first webinar. Most of you who are on the first webinar know that the idea for our second webinar was to do with Dr. Julia Wickstrom from Sweden to talk about biopsies, but she's on the front line of the response in her country in Sweden, so wasn't able to do it in this time frame. And we thought it was a good chance to take advantage of this kind of insane and incredible time that we're in, and talk about a topic which is important to those that are working with patients with CKDu or other kidney outcomes, and also for those of us working with communities. It's a really important topic for our communities. So that being said, we're happy to just take a time tonight or this morning to hear perspectives from different parts of the world, and hopefully generate a rich discussion which should be helpful for lots of us. So having said that, welcome. I counted quickly. I think there are about seven countries at least connected tonight. So thank you for everyone for joining us, and I'll pass to Marvin to do the introductions.
Okay, good night to everybody, and thank you for joining. My name is Marvin Gonzalez. I'm the co-chair of CENCAM board. I work at the National Autonomous University in Nicaragua at the Research Center of Health, Work, and Environment system. I've been working for more than 10 years on this epidemic, and I've been involved with the visibility and engagement subcommittee working on this idea to develop the webinar, and also working very close with the clinical subcommittee as well. Tonight we have three great speakers. We have Dr. Sushi Anand from United States, and Dr. Nishanta Nayakara from Sri Lanka, and Dr. Vicente Sanchez Polo from Guatemala. All of them are nephrologists, well-trained nephrologists, and they had a lot of expertise on CKD and also CKDu. And now they are on the front line of COVID-19. They are providing medical care in the dialysis unit. So they are the best expert on this topic. So we are going to start with, I'm going to start to introduce Dr. Sushi Anand. She is a nephrologist, and she is an assistant professor of medicine at the Stanford University. Also, she's the director of the Center for Interstitial Kidney Disease at Stanford University. She received her medical degree from Washington University School of Medicine in St. Louis. And then she completed her internal medicine in Boston. And she completed as well her master in clinical epidemiology and nephrology fellow at Stanford University. Welcome, Dr. Asushi Anand, and the scenario is all yours.
Great, thank you so much, Marvin. Thank you, Jenny, also for hosting and moderating. So I just wanted to start by saying that I'm certainly not an expert in this topic, but I do have a high interest. I'm a careful and avid digester of all information related to COVID-19 in the kidney. And part of that reason actually is because of my interest in CKDu and MeN, and I come to the discussion about COVID-19 in the kidney through my lens, looking at CKDu and MeN. So hopefully that will be of interest to the audience that's listening tonight, partly because there is at least one of the hypotheses around what is potentially causing CKDu or MeN is that it could potentially be an infection, and partly also because both of these diseases, while not on the same scale, as a pandemic that's occurring in, around COVID-19, have had significant public health implications for the regions where they are considered to be an epidemic. Sorry, I'm just trying to advance. Technical difficulty here, guys. 1 second.
Sometimes it takes a few for some reason.
Yeah. Let me try from this side. Okay. This is just a disclosure and acknowledgments. I have lots of gratefulness and thankfulness for all the funding agencies that have supported my work. And as many of you may recognize, this is the deceptively simple structure of the SARS-CoV-2 virus, which has the distinctive the membrane protein, the spike membrane protein. So I am going to try to be truly brief and allow the stage to really go to Dr. Nanyakara and Dr. Vicente Sanchez-Paulo, who are really battling the epidemic and the front lines in CKD endemic areas. But I wanted to touch on three major things. One about the prevalence of acute kidney injury in COVID-19, and then have a brief discussion about what potentially is causing the acute kidney injury. Then talk about what potential treatments we have to offer. And then lastly, and this sort of heads off to my colleagues, is the planning for provision of dialysis in the era of the COVID-19 pandemic. So much like, actually this really reminded me of the controversies and discussions that we've been having around CKDu and MeN. There has been a lot of confusion about what is the true prevalence of acute kidney injury and of background kidney disease in patients who are affected by COVID-19. So some of the initial data coming from Wuhan, some of these were published initially, as some of you may know, in the New England Journal back in February, said that actually not many people who were hospitalized in Wuhan, of the 1,500 people that were described in that case series, had underlying kidney disease. So 0.71% was the estimate. And also not many people had acute kidney injury, about 0.5% only. And when I looked at the definitions of how people define acute kidney injury, it was very strictly defined, and it was a low incident, low prevalence reported. Then later on, from similar data from China, but from a much more COVID-19 designated hospital, the prevalence of AKI was reported to be higher, about 15%, and the need for renal replacement therapy in 5%. This is from data published in the Lancet by Zhu et al. In Italy, where the second sort of wave of the epidemic hit, the data on pre-existing kidney disease was widely varying as well, between 3 to 18%, and you would expect the pre-existing kidney disease prevalence to be higher because this is supposedly an older population. And the data on AKI has only been reported to the institute that sort of represents the NIH in Italy. So the National Institutes of Health has a data collecting arm, and data reported to that institute loosely defines AKI and reports a prevalence of 28%, so just much higher than what was initially reported from China. About 2,000 people had contributed data to this registry in Italy at the time that I was looking. In New York, where the sort of the epicenter has been in the US, most of the data coming out from New York City has come from a chain of hospitals called Northwell Hospitals. There are 23 hospitals located throughout New York. And they report a pre-existing kidney disease prevalence of anywhere from 8 to 18%. And approximately 3 to 4% of these patients are on dialysis. So it's pre-existing kidney disease of any stage, including dialysis, and about 3 to 4% of patients of the 5,000 or so reported in their case series have had pre-existing kidney disease. And they report a much higher prevalence of acute kidney injury, approximately 37% with some form of acute kidney injury. And in fact, when we very strictly define acute kidney injury, most commonly, 80 to 90% of the time, it's relatively mild. But in the case series described here, acute kidney injury that was substantial, that would be clinically recognized by all of us caring for those patients, occurred in over 50% of the patients with acute kidney injury. And renal replacement therapy was required by 5%. So renal replacement therapy, by that I mean dialysis or acute peritoneal dialysis required by 5%. And that may not seem like a big proportion, but if you think about it, this is in the period of approximately a month. And that's 5,000 patients flooding in with COVID-19 to the system, and about 300 of them need dialysis. So most hospitals don't have, 300 independent dialysis machines available to undertake dialysis in this setting. And there was, you may have seen in the press, there was a lot of publicization of the scarcity of dialysis equipment because the systems were overwhelmed in New York. So in this paper by Hirsch et al. That was recently published in Kidney in Print, but published online, they looked at, one of the ways that they looked at what was potentially causing the kidney injury is that they looked at timing of the kidney injury. And so the yellow lines are where patients started dialysis, and the sort of the curve is when they were intubated to help support their breathing. So these are obviously severely ill patients, but you can see that the yellow lines kind of peak at the same time around the time of the intubation. So they really proposed that patients who had very severe kidney injury and needed dialysis mostly required it to help them manage volume, to help them manage fluid status around the time that they were getting really, really sick and needing help breathing. That's the time that patients are really getting into the cytokine storm, which you may have heard about, that occurs with COVID-19. Plus, they were developing respiratory failure, which meant that the teams caring for them would be very judicious about giving them any fluid. So that would all cause what's called low perfusion, low blood flow to the kidney, and cause acute tubular injury, which is the most common cause of kidney failure in hospitalized patients. So they very reasonably hypothesized that that is likely to be the most common cause of a severe acute kidney injury in patients with COVID-19 is acute tubular necrosis. But what was interesting, and they pointed this out as well, and other data from China have corroborated this also, is when people have acute kidney injury, they usually don't have much protein leak, much inflammatory, much signal of inflammation in their urinary tract, but that was not necessarily the case for this subset of patients for whom they did have urine. So not every one of the patients did they have urine for, but the patients on whom they had urine data, about 600 of them, many of them had significant protein leak in their urine assessment, and many of them had white blood cells and red blood cells in their microscopy, which was at least an intriguing finding, and something similar has been reported from data from China as well. So that raises the possibility that while it's true, this is a schematic for what could be causing acute kidney injury when people have SARS-CoV-2 infection, what could be true, the more commonly known reasons, which is the cytokine storm and people getting very sick, as well as having respiratory failure and therefore needing less fluid, very judicious use of fluid, is what's causing the kidney injury. The additional thought is, well, maybe is there direct involvement of the kidney tissue by the SARS-CoV-2 virus. And the hypothesis, sort of the theoretical reasons for this hypothesis are that the receptor in the body that binds the SARS-CoV-2 virus is also present in the kidney. So the ACE2 receptor is present in abundance in the lung, but also present in relatively high abundance in the glomerulus and also in the proximal tubular cells of the kidney. And that is an intriguing observation, and to investigate whether this is possibly a true hypothesis. People have looked at autopsy series. So this is I want to say 6 autopsies performed in China pretty much immediately at around the time of death of these patients, and looking at their kidney tissue to see if they can identify the virus infecting the kidney. And I don't know how well this is projecting, but if you can see, they did a nice job of putting their arrows right at where you could potentially make out a circular structure with some spikes coming out of it that's very, very suspicious of potential virus presence. And they saw it in the tubular cells in the kidney, and they also saw it in some of the parts of the glomerulus in the kidney. And subsequent data series from a single autopsy case was published in another journal. So this was published in Kidney International, and then another one was published in the Journal of American Society of Nephrology, where they did an autopsy and noted something similar. And a third case also reported, so potentially 3 publications, 2 of which were autopsy series reporting potential presence of virus in the kidney. And also of note, in these case series, in the patients who unfortunately died from COVID-19, there was also overwhelming tubular injury and tubular necrosis, also supporting the first hypothesis that these patients have ATN. But the caveat to this is, this was a letter published right after the initial publication of the autopsy series from China, that, well, are we getting faked out here? Maybe these are not actual virus cells, but these are what's called microvesicular bodies. So basically things that the kidney processes and essentially cell turnover tissue that the kidney has processed and put in this shape. And these are microvesicular bodies, and you can see they look remarkably similar to the viruses the purported virus particles that were highlighted in the prior slide. And the authors of this letter to Kidney International said that microvesicular bodies are present in pretty much all kidney biopsies, and so they weren't convinced by the current evidence that that the virus truly is in the kidney. Of note, in the prior autopsy series, they did also do something special called immunohistochemistry, where they try to stain for the parts of the virus that I showed you. And they, in 3 of the 6 cases, they said they identified a nuclear protein from the virus in the kidney as well. But on the other hand, supporting this hypothesis that maybe there isn't virus in the kidney and we're getting faked out by just the images, and these are really some normal parts of the kidney. People have looked at whether there is viral shedding in urine. So they've looked at viral shedding in many different specimens and that have been obtained from patients with COVID-19. And when they looked at 72 urine samples, none of them were were positive for the virus by PCR testing. I looked at other studies. There's another publication of about 14 urine samples that was also negative. There are a couple of publications where out of 10 urine samples, 1 was positive, and another case report where 1 urine specimen was positive as well. But a majority of the urine specimens that have been published in the literature have been negative by PCR for presence of the virus, further supporting this hypothesis. Maybe we're not really seeing virus in the kidney. So I think this is a slide of this is a slide sort of tying it back to CKDu MEN. So this is the black arrowheads there are pointing at leptospira. And as some of you may know, leptospirosis has been hypothesized to be a cause of, potentially a cause of CKDu and MEN. And we still don't have clarity, much like in the questions that we still have about potential direct invasion of the SARS-CoV-2 virus into the kidney. So I think I think the science on SARS-CoV-2 is evolving fast, and I think we just have more patients as well, unfortunately, where hopefully we will be doing further studies on their kidney specimens and their urine specimens, and that can really help inform our search or our investigation of the hypothesis of whether potentially there's an infection implicated in CKDu and MEN. So moving on to, in terms of treatment, what we have to offer for patients with COVID-19 who have either pre-existing kidney disease or developed kidney disease during their infection. So these are snapshots I took from social media from Dr. Chartian and his group at NYU, where again, because of the scarcity of the dialysis machines, one thing that their group came up with was instituting acute peritoneal dialysis in patients who develop severe acute kidney injury requiring replacement therapy. And also that another way that they have allocated resources is actually reduce the frequency from 3 to 2 times a week. And I don't need to tell some of the practicing nephrologists and clinicians in the areas in where CKDu is endemic, these are all therapies that sort of have been developed in and have been informed by practices in low resource settings. So here, people had a leg to stand on because low resource settings have been using acute peritoneal dialysis. They've been using 2 times weekly dialysis for much longer. And thankfully, we do have some crosstalk now with great publications coming out from sharing their experience and allowing, informing hopefully the practice in New York as well. In terms of people who potentially develop AKI or have pre-existing kidney disease, so these are data from the hot off the press from the New England Journal looking at remdesivir, which is an antiviral which has shown some efficacy in reducing the time spent in the hospital for patients who at least have moderate COVID-19, so patients who are not necessarily requiring invasive high flow oxygen or requiring invasive mechanical ventilation, but patients who may have been hospitalized with moderate COVID-19 seem to benefit from use of remdesivir. Unfortunately, though, this study and the study prior to that, which looked at the different dosing schedules of remdesivir, excluded people with kidney disease. The first study excluded people with kidney disease with EGFR less than 50. This study excluded people at EGFR less than 30. With rationale that's not quite clear. I think their concern was about the carrier that remdesivir is provided in. It's an intravenous drug and is provided in this intravenous carrier. And there was concern that that carrier causes kidney injury and therefore it wasn't offered to patients with kidney disease, but that carrier has been used previously and it hasn't, that concern is essentially debunked. So I think it really does limit it limits our hand now that remdesivir is standard of care. We still potentially cannot offer it to patients on dialysis and cannot offer it to our patients who have moderate kidney disease because we haven't studied it. And so it'll, at least, at the very least, there'll be a lag in providing this treatment to our patients because of the exclusion in these studies. And then now let's just moving on to looking at planning for dialysis during COVID-19 pandemic. This is just a picture. This is taken off the Fresenius website, but it just shows you that patients on dialysis, like they have direct healthcare contact 3 times a week. They cannot self-quarantine, or 2 to 3 times a week, they cannot self-quarantine. They need their blood accessed 2 to 3 times a week. And they are around people who are also not self-quarantined because they have to come to the units and also at high risk for COVID-19. Plus, some of them are frail and elderly and do not have the same immune responses that you and I may have to an infection. These are data from Wuhan, from a single unit in Wuhan where they dialyzed 230 patients for over the course of about a month. And you can see that during that time period, just like in the rest of the population, once the number of cases hit a certain threshold, those cases really shot up. And with extensive screening and isolation, they were able to reduce the load on the unit in terms of the numbers of cases. And then what was also interesting is then they looked at causes of death. And so in this 1 month period, unfortunately, of the 230 patients, 7 died. And 6 of the patients who died with COVID-19 did not die from COVID-19 pneumonia, but rather died likely because they missed dialysis. And I think I don't know if that was self-sacrificial or if maybe they, because they had the diagnosis and they felt really guilty about going to dialysis potentially, or maybe the dialysis facilities that they were designated to were too far, too impractical to get to. And that's potentially what led to the death. Only 1 of these 7 died of the pneumonia itself, but the remaining died of complications of possibly missed dialysis. These are data from Kidney International. It's a small case series from it's still heroically done case series from Spain, where they showed, not surprisingly, that more patients who have COVID-19 and are in dialysis die from COVID-19. Once they're hospitalized, they have a higher mortality rate than what's quoted in the general population. There are, societies hard at work at addressing this issue of addressing how we can reduce the exposure to our patients. And the CDC has a preparedness checklist, which is available on their website. And then the ERAEDTA made this really nice graphic looking at some very common sense things that can be done to to help reduce exposure to healthcare workers as well as to the patients. And one of the major things is screening. And I want to note that the screening does not currently, or in neither of these recommendations or any of the recommendations that I saw from the ISN, ASN, CDC, ERA, EDTA. I did not see one from SLAN, but none of these other organizations had recommendations around screening by testing, but they had recommendations around temperature screening and symptom screening. And they also had recommendations around if patients have symptoms, that they should be dialyzed in either different shifts or in like shifts collectively, that where all patients who are symptomatic are dialyzed together, or in different units altogether. But I just wanted to show you some data from a unit in Indiana where they did follow some of these really common sense protocols of wearing masks, having patients dialyzed in different isolation area. In this unit, this is a pediatric unit where one patient had COVID-19 symptomatically at day 0 of the study, and you can see the number of patients, about 20% of their patients seroconverted during the next 21 days, and close to 40% of their healthcare workers seroconverted during the next 21 days. Now, they can't rule out that this is not community transmission that these patients are getting, but it's highly suspicious that some of the transmission is potentially occurring within the dialysis unit. Thankfully, only 2 of the healthcare workers had some symptoms, and no one was, the remaining were just asymptomatic seroconversions. But I think what the guidelines leave unsaid, and which hopefully my colleagues will address in the next subsequent talks, is testing. Like, do we need to test our patients on dialysis who are coming to our units? Who do we test? Do we test everyone? How frequently do we test them? And who does the test? Is it the dialysis unit that's responsible? Is it the primary care unit? Who is responsible for actually administering the test? Is it the dialysis nurse, or should there be someone more specialized available to do the test? And then, the recommendation about isolating, but that's a great recommendation, but how do we know how much to plan for? How many chairs do we need to be isolated? How many units may need to be only COVID-19 units, and how much PPE will we need for our staff? And should we maybe be checking our staff to see if they have seroconverted already, and maybe preferentially putting them in the COVID-19 units? But then ultimately it becomes an issue about trust from our patients' perspective, because they are in a long-term therapeutic relationship with us. We're giving them something that is a life-saving therapy. And so how do we protect them and protect ourselves? There's hugely a role for advocacy, because like I said, sometimes our patients are neglected from clinical trials, and we really need to advocate for them to be included in clinical trials that are testing therapies and vaccines, but also potentially a role for prophylaxis here, because of the factors that we talked about not being able to self-quarantine, about always needing contact with the healthcare personnel and with other high-risk patients. So I want to stop here. Thank you. This is hopefully a segue to Dr. Nanya Kara's talk, where he'll discuss some of these issues as well. And I really want to thank people who are on the line, some of whom are, I know, frontline healthcare workers and who are dealing with this epidemic on a day-to-day basis. We've been lucky here in California, but I know that's not the case in many other areas. So thank you for your time.
Thank you, Suchi, for this great presentation and give us an idea how is the trends of kidney injury and COVID in different parts of the world. Our next speaker is Dr. Nishanta Nayakara. He's from Sri Lanka, and also he is a nephrologist. He's working at the Kandy Teaching Hospital in Kandy, Sri Lanka. And he's He is an advisor to the Center for the Education, Research and Training in Kidney Disease in Faculty of Medicine, the University of Peradeniya, which is one of the leading institutes investigating the current epidemic chronic kidney disease of unknown etiology. And also he is providing medical care in those in the most affected area of CKDu in Sri Lanka. Welcome, Dr. Nishanta, and thank you for joining us.
Yeah, thank you, Marvin, for the kind introduction, and thank you for CKDu organizing this timely event. And again, another thank for inviting for me to talk on our experience in peritoneal dialysis and under this endemic situation. Yeah, so I will try to talk a little on the peritoneal dialysis and under this epidemic situation in Sri Lanka. So, we are having estimated number of stage failure around 4,000, and on top of this, the other CKDs like hypertensive, diabetic, chronic kidney diseases. We are having a particular problem that is a chronic kidney disease of uncertain etiology, is prevalent in parts of the country, especially in the dry farming area. So they are mainly paddy farming areas, and the main problem is the providing the renal therapy. So as a treatment, we had only live donor kidney transplantation, but the live donor kidney transplantation is always possible because in the endemic areas, it's very difficult to find the donors as the donors, their family members sharing the same risk factors for CKDu. So hardly we don't expect the people to donate kidneys. So we are in a situation that where the treatment is not freely available and the patients are waiting for treatment. So several hemodialysis units, but the problem is most of the units are overcrowded, and as a result, the people don't receive a proper or a standard 3 times a week dialysis, and under dialysis is very common. So as another option, the CAPD program was initiated in 2014, and currently we are having 2 main units for peritoneal dialysis. One is in north part of the country, and the other one is in the center. And in the several other units around the country, CAPD started, and we are continuing as a treatment. Altogether, we are having little more than 300 patients. So this is Sri Lanka. So if you look at the Sri Lanka, there is a green area and a yellow area. So this greenish area is the dry zone, and in the dry zone you see several red areas. So those red areas are the areas where the CKDu is more prevalent. So they are not throughout the dry zone. They are only limited to some locations. So still we don't know what are the specific associations in these the hot areas, and even in these hot areas, it's not evenly distributed. You see sort of small areas where the disease is there, but some adjacent areas it is not equally affected. We are having 3 units actually. So the main unit in the Kandy hospital and 2 satellite units far away from the Kandy, so around 100 kilometers away. One place is called Giradukotte, the other one is Vilgam. Both are affected by CKDu, the chronic disease of uncertain etiology. if you take the total population prevalence, the CKD prevalence is around 5%. But if you take the age-specific population, and if it is between 40 to 60, the CKDu prevalence goes up to 15 to 20%. And the sad story is, so if you analyze the data, retrospective data, the survival of CKDu is very poor. So if you take 100 patients, around more than 90 die of end-stage renal failure, and only 5% was offered renal replacement therapy. So that is the main reason for starting this peritoneal dialysis program, because we have to respect their independency. And again, so the people traveling this long, so 100 kilometers for dialysis is not very impossible, especially because they are not straight away from those areas, and they have to come another 10-15 kilometers to take a transport facility to main hospitals. So in Kandy, we are having 150 patients, 120 in the main center, and another 25 in one rural area, and another 8 in another area. So mainly the catheter insertion, training, initiation, and management of complications, and that main unit, as the facilities are not that satisfactory to support those things in peripheries. So main unit is equipped by 1 medical officer and 9 nursing officers, and unit is occupied by 2 consultants. Actually, now we are having 3. So catheters are regularly inserted by transplant surgeons as inward the procedure. So you need at least 3-day hospital stay to get a catheter in, and patients are coming for flushing on 5th and 10th day, and we initiate 4 to 6 patients per week, new patients per week on peritoneal dialysis. So this was a brief report on the initiation of this program to discuss what was the background for initiation of this program, and routinely patients got admitted to the unit for training and initiation. So the average hospital stay is 4 days. All patients visit hospital monthly for review, drugs, and concerns. So these are the things we took into account when we are going to face an epidemic, especially an infection. So most of the patients from all around the country, they are up and around the hospital. So this is a high-risk situation. So that we have to manage for preventing them getting infected. So we are having monthly training. So it is the ministry requirement. So we can't give the consumables or a CPD fluid or other drugs for more than a month of period. And the peritonitis again treated as inpatient. So we have to keep patients 10 to 14 days of initial continuous phase of antibiotics followed by 7-day intermittent antibiotics. So we tried this from the beginning. We tried these intermittent regimes, but so most of the they follow the requirement. So we have to treat the first phase with IV antibiotics. And patent adequacy we want to do relatively, so it's not a big issue for us. And most other complications managed as inpatient in the main hospital. So this was the workshop we had a few months before this COVID period, and we had a big support from International Society of Nephrology, Sri Lankan Society of Nephrology, and again the International Society of Peritoneal Dialysis, and they were very well respected few speakers from all over the world, and it was a success story. So this is the story of COVID-19 in Sri Lanka. The first case was reported well before it was in January. So she was a tourist from China. She visited the country and she went all around, even the Kandy. She was there for a couple of days. And all the contacts were traced, isolated, but luckily nobody became positive. And later, so once this the epidemic in Wuhan identified, and it was going to other countries, spread to other countries, all the flights from China was cancelled, and if somebody is coming from China, so they were quarantined to limit the. Then the disease spread or reported from European countries. So as a result, there were large number of people working there, and some sort of returned to the Sri Lanka. So at that time, the people were not quarantined. So they went their home, and so this was a problem. And then later, some cases were reported from their close contacts. So this is the situation at the moment. So actually the real first case from Sri Lanka was reported in the early March, and the numbers are rising. So currently the 1,500 cases were reported, and luckily we had only 10 deaths, and some hospitalized, and they are under surveillance. So in the mid-March, all the airports were closed, and the curfew was implemented throughout the country. And the most contacts were traced and quarantined during that period. So within sort of 2 weeks period, so it looks under control. And unfortunately, there was an incident with the drug addicts. So there were some drug addicts among these contacts, and they were sort of trying to escape from forces, and the forces were trying hard to catch them. So as a result, the Navy personnel got infected. So now the Navy camp, so with 4,000 the Navy officers, and all were quarantined, and out of them, I think it's more than 500 people got the COVID infection, but they are very young, active people. So luckily, nobody had a serious the complications to the date, and there were no deaths, and nobody was in ICU, and all were very mild, and some even asymptomatic. So this is the COVID map and the CKDu map. So if you look at the COVID map, it's in the it's limited to the Colombo, the main city of the country, and there are a few cases reported from the other areas. But most of these cases either straight away coming from abroad or the Navy personnel. And to the date, there was no community spread in the country, and the CKDu areas are sort of little far away from even though there are some cases reported from these areas. So they were traced, and they were quarantined, and there was no community spread in these affected areas with the disease. So this is a response from the Ministry of Health with this epidemic situation, and several hospitals, including Kandy, were identified as treatment center for the infection. And all staff were advised to follow strict infection control measures. And unless in an emergency, patients were advised not to visit hospitals, and there were some hotlines to get the health advice if they are having some other illness, or if they are having symptoms of suspected COVID. And all routine procedures, clinics, and surgeries were cancelled, and number of staff were reduced to half or 1/3 to run the emergencies. And all suspected and contacts were treated in dedicated wards with strict infection control measures. So this was our preparedness for this epidemic, and some of the wards were converted to COVID wards and COVID suspected wards. And we also had a dialysis unit that was for people who are coming with contact history or suspected symptoms of COVID. So we were also prepared, and we were dialyzing few patients, suspected patients, with a contact history, but nobody had COVID infection in our hospital. But to one dialysis patient and one kidney transplant patient had the disease. So luckily this dialysis patient, he recovered, and the transplant patients, he succumbed to it. And out of it, there were 2 other chronic kidney disease patients. They were at the multiple medical problems like diabetes, hypertension, and chronic kidney disease. So out of the 10 deaths, there were 3 CKDu patients. So this is the response from us. So our staff were advised to follow infection control measures. All hospital attendees were screened at the entrance for possible COVID contact or possible symptoms, and all routine procedures, including kidney transplants for cancer. But the peritoneal dialysis or CKD, we identify as life-saving, and so we continue. And the hospital admissions were limited to emergencies, but CKD training identified as life-saving, and it was continued. Home delivery of drugs, including CKD concentrates, were planned and implemented. And hemodialysis, we had to continue by providing special unit for these COVID suspected ones. The other main units were continued as normal, and suspected or contacts were dialyzed in a dedicated unit with strict the infection control measures. So this is the transplant and the dialysis unit of Kandy Hospital. And the continuous peritoneal dialysis, while we are expecting the epidemic. So as I mentioned earlier, training, catheter insertion and initiation continued as we wrote that they are life-saving. And again, we don't want to initiate hemodialysis to make it make it a overburden to the hospital, as well as then the people, they have to come regularly to the hospital. So avoid that. We didn't want to put people on hemodialysis, and we try to promote peritoneal dialysis, because then we can keep away from the hospital and keep away from the contacts or possible infection sources. If somebody is unwell, so we were trying to exclude contact or possibility of COVID, and no patients were admitted to the regular wards. If they are having suspected symptoms, they will be going to COVID suspected, or there's a dedicated ward for COVID if they are confirmed. And regular patients were advised not to visit the hospital, and hot number is activated for their medical advisors, and the consumables were delivered to doorstep or to authorized person who may be one of the relative or a close friend or somebody like that. And early change to intermittent regime has been considered for peritonitis. So this even during the epidemic situation, so we were training and initiating the patients on peritoneal dialysis. So our main challenge or our main focus was to keep adequate control of CKD concentrates for the patients during the epidemic. So we are having one supplier of peritoneal dialysis up to 2019, and 2 others got registration. There's a very hectic procedure to get registration in our ministry, so it takes at least 1.5 to 2 years. And so with our push and the ministry wanted to expedite it. With that help also, it took at least 2 years to get the registration. The main supply is importing the fluid from Philippines, and even without the epidemic or under normal circumstances, also we are facing huge gaps of supply, and sometimes the patients has to come weekly to get their the concentrate or the peritoneal fluid. So it's very big headache for us, and daily we are sort of contacting the ministry people, having discussions, but still it's not regular. So the supplier has some stocks, but Ministry of Health or the hospitals do not have any stocks. They purchase fluid on demand. So this is a big problem. If we don't get enough supplies, how to sort of provide the dialysis? And we sort of personally contact all 3 companies and advise the manufacturers or importers to ensure interrupted supply. And authorities were informed that we have to continue it without major disturbance, and otherwise there will be a big crisis. So we were trying very hard to keep the stocks, and we were expecting the worst. So if we don't get enough supplies, what to do? And we advise patients that you may sort of experience some lapsing supplies, so try to sort of continue with the minimum possible treatments. But again, we were not advising it too hard. Sometimes they may take it lightly, and so with the discussion of the staff, we try to keep some fluid by ready in a case of we don't have the enough stocks. So, and we were trying to categorize patients based on their dialysis requirement, and patients who is having good residual function. So we were thinking of whether to stop it temporarily or to reduce the frequency of exchanges. But we can't sort of play around with if the people are not having residual renal function. So the only available option would be the immediate change to hemodialysis. So this was our experience with this one. And luckily, we didn't really facing the epidemic. So only the measure we were facing some crisis with the measures taken to stop the spread of the disease. So I'm not sure what will happen in the future, because still the people are coming, but the whole quarantine centers, because last week we received lots of people from Middle East, and at least half or a part of them got infected. So if community spread starts, so some of the things I have discussed here may not be. We have to fix the real situation. Okay, thank you again for giving me the opportunity, and thank you for your patience.
Thank you, Nishanta, for giving us a whole picture about how Sri Lanka was prepared for attending those patients that can develop AKI due to COVID-19. So our next speaker is from Central America. He's Dr. Vicente Sanchez Polo. He's a nephrologist, and he's the chief of nephrology and kidney transplantation of Department of Internal Medicine, General Hospital, Guatemalan Social Security Institute, and the medical school at San Carlos University. Also, he is coordinating and founder of the nephrology residence and fellows program, and member of the SENCAN board. Also, he is coordinating the Mesoamerican Nephropathy subcommittee at the SLAN of the SLAN Society. And also he is member of the ASN, ISN, and the SLAN and the Guatemalan Nephrology Society. Welcome, Dr. Vicente Sanchez Polo.
Thank you, Marvin. Thank you, Jenny. And I'm so glad to be with you here. And I'm going to talk about what's going on in Guatemala, caring for patients from hemodialysis in Guatemala in the time of COVID-19 for flag-flung areas to dialysis chair. I don't have any conflict of interest. As you know, Guatemala is well located in Central America, what they call whole tropical countries, surrounded by our big brother Mexico, El Salvador, Honduras, Nicaragua, Costa Rica, and Panama. This region is called Mesoamerica because we share some cultural issues, alimentary issues, and our history and background is almost the same. Formal and informal agricultural, highlands in Guatemala and Mexico, and tropical regions in rest of the subcontinent in Central America. We eat a lot of corn, and the poverty is one of the cardinal things here in our region. Guatemala is a beautiful country. Its richness in culture. The Maya civilization was founded also in early the 1000 after Jesus Christ. We was conquered by the Spanish civilization in early 15th century, and Guatemala is a beautiful place to live and also to travel for tourism. Is plenty of beautiful people, hard workers, pretty women, and of course, handsome men. What kind of country we are talking about? We are 16 million of inhabitants. This is most of them are younger population. This is really important. 42% are Indian, come from the Maya civilization, and 55% in rural population. Guatemala is in the heart of Central America, as we call the Mesoamerican. There's the name of Mesoamerican nephropathy because here in Central America, particularly in El Salvador and Nicaragua, was described by our colleagues. Our human development is so bad, is one of the bad indexes of development in Latin America. 3 or 5 of our citizens live in poverty, and 3 of 10 of adults can read or write just here in Guatemala. Our average income, as you see here, is lower than US and Mexico. The inflation rate is 7%. The minimum wage is $250 per month, and the cost in dialysis care is $600 a month in US peritoneal dialysis. The cost for transplantation is between $3,000 and $4,000 US per year. The immunosuppressants that we are available is tacrolimus, astatoprim, prednisone, mycophenolate, tacrolimus, prednisone. With the difference in the cost are amazing. In terms of CKD incidence in Guatemala, notice that the patients who require dialysis in terms of incidence are 166 patients per million inhabitants. As we compare with Latin American registry, they had 145 patients per million inhabitants. So the incidence of patients who require dialysis in Guatemala is higher than in the rest of the continent. But what about prevalence? The prevalence of patients in dialysis in Guatemala is also higher than in Latin America. Our national registry almost finished a really good work. I want to congratulate them because they demonstrate us that the prevalence of patients in dialysis in Guatemala at the moment is 801 patients per million inhabitants. In Latin America is 709 patients per million inhabitants. Our total cases that are requiring a renal replacement therapy in Guatemala are more than 9,000. Hemodialysis are almost 6,000, and peritoneal dialysis 4,000 people taking peritoneal dialysis in Guatemala. So what's the reason of that? We think that we are growing in more CKD programs. They are better referral because we have nephrologists in the highland, nephrologists in the southern part, in the most cities of Guatemala. We are growing in the number of nephrologists at this moment. We was in the past between 4 or 5 per million inhabitants. At this moment, we are 8 nephrologists per million. It's instead low, but we are working hard in increase that. The presence of traditional causes are important: diabetes, hypertension, syndrome, metabolic syndrome. Diabetes is the 35% of CKD caused in Guatemala, but also we have non-traditional CKD like Mesoamerican nephropathy, and our registry tells us that between 12 and 50% of our patients are, the reason of that is Mesoamerican nephropathy. So where are the patients? This is a density of color density, the southern part near the Pacific Ocean, and each blue color represents the incidence and prevalence actually of our patients that develop CKD that are on dialysis. This is Guatemala City, Antigua Guatemala, and the second largest city, Quetzaltenango, and every region, what we call Southern Guatemala, what we call in Spanish Costa Sur, because it's in the south and near the Pacific coast, are the hot spots of the CKD called Mesoamerican nephropathy, and in urban centers are the hotspots of traditional nephropathy as diabetes and hypertension. In this publication by Tim Locks and Joaquin Barnoya, they tell us the same situation. If you put the heat map stroke. Look at that. Those are the hottest areas in Guatemala, and if you put exactly the map of where the kidney patients are, you look exactly the same situation are located in the southern part where the temperature is higher, and in the city of Guatemala and in Quetzaltenango, which is the second city. In our publication that we try to demonstrate what's going on in Southwest Guatemala in hemodialysis patients, we saw every patient that undergo hemodialysis in the center. This is the southern part of Guatemala. As you see, non-traditional cause in southern part are 74% of our people that are on hemodialysis are non-traditional reason. They are non-diabetic, they are non-hypertension, they have the characteristic of clinical case of Mesoamerican nephropathy. They are young people, they live below 300 meters, agricultural, they use non-steroidal disinflammatories, they drink beverages based on fructose, uric acid, potassium, and almost 90% are main agricultural workers. So, in terms of COVID, Guatemala, I'm talking about what's going on exactly in the southern part of Guatemala. We're going to forget about the cities, the big cities, because there is a crazy situation here and the second city and in the highlands. But in terms of the talk, the purpose of the talk is to talking about what's going on in the southern part of Guatemala, where particularly our Mesoamerican nephropathy patients live. So we provide 3 Sentinel hospitals, one in Quetzaltenango, one in Mazatenango, one in Escuintla. So the patients that have suspicions or positive case of COVID, they are referred to this hospital. So by the purpose of the talk, we're talking about the Sentinel Hospital of the Social Security program in Guatemala. At this moment, early 5 or 10 minutes ago, what is the situation of COVID in Guatemala? Our first case was reported on March 13 of 2020. At this moment, we have more than 4,000 cases, 78 deaths, but just today died 12 people, recovered 565 people. Our health system is collapsed at the moment, particularly in the big cities, and many of the patients come from urban centers and the highlands. For a reason that we know, maybe we miss the data, the data registry is not acute, is not well developed. So for this reason, maybe in the southern Guatemala, there are not reported a lot of cases. Maybe we don't know exactly what's going on there. So in terms of hemodialysis patients in our southern part, we are running 5 or 6 patients. It's divided in 3 big cities in the south, 218 in Escuintla, 124 in Mazatenango, and 164 in Retaluleu. So the total of patients that we are running in 3 clinics, 3 major clinics, are 5 or 6 patients. What's going on in terms of COVID? We are just suspect 4 cases in Escuintla, 5 cases in Retaluleu, and 4 cases in Mazatenango. This is the fount of the Medicorp, and no positive cases at this moment. So we think that the results are good. This is again Guatemala City, Quetzaltenango, the second city. Here is Retaluleu, Mazatenango, and Escuintla, where the hemodialysis units are located. So the people from this area don't come to Guatemala City and don't come to Quetzaltenango. They have their own Sentinel hospitals and their own protocols to treat the patients that are suspicious or positive COVID. This is our Mazatenango unit. This is our Escuintla unit, Dr. Wendy Pivaral. She is the director of there. And this is our Retaluleu unit, Dr. Jose Antonio Quiroa. He is the director over there. How are our indicator of dialysis in these 3 units? Almost 72% are with fistula. The KT/V are really good. Almost 95% this is during COVID time. They try to maintain the 4 hours time. Our labs, 63% are in this albumina, 79% with phosphorus. Hemoglobin higher than 10, 68%. The mortality is 706, and the quality of hour of the water is okay. And the number of dialysis machines in total are 82 to treat, as you told you, more than 500 patients. patients. What we do in our dialysis units is practically what everybody in the world doing. This is some suggestions of Latin American Society of Nephrology in share with the Latin American Transplantation Society with the support of the Pan American Society of the Health Pan American Society with called PAHO. And what particularly we do is the hemodialysis prescription we think is really important. We need to try to maintain this hemodialysis prescription. It's not easy for the patients. They are fearless to come to the dialysis more than 1 or 2. They try to, don't go to this middle shift between Monday and Friday. They want to not came on Wednesday, but the compliance is really important. And the influence of the nephrologist is particularly the most important thing, because what the nephrologists tell to the patient is like a law. It's really important to maintain the influence of the nephrology. To try to reach the 4 hours 3 times a week, to maintain the QS, to maintain the dry weight is to try to not ultrafiltrate more than 2.5 kilos per session, heparin as needed, and stick with the diet. The diet is really important to try to maintain and to try to reach the goals in the every hemodialysis. Every unit, in general measures, what they do is that the patients use their own transportation. We try to not use public transportation. It suggests for them. In the southern coast of Guatemala, there are plenty of possibilities so they can travel by own cars, by some taxis. Of course, we consider public, but they want to pay the car service, or they can go in the same city by bicycle, or by motorcycle, but they try to, we suggest not to use public transportations. The patients enter to the clinic by themselves without any family or caregiver. So they be at the street, say goodbye to the family or caregiver, and go entry the dialysis unit. The cafeteria of the clinic is closed. Remember, here in Guatemala, we give them one food after or before the hemodialysis. Those was canceled at this moment. The waiting room is closed, of course, and the family and caregivers entry is prohibited. What about hemodialysis staff? Every patient goes on the triage practically in the street before getting the hemoclinic. They take temperature, a questionnaire. The health staff without fever and symptoms, of course. They are very well protected and with all the equipment. We are talking about the hemodialysis staff. And every shift they have coat, N95 mask, Google Eyes protector, and every patient wash hands with water, surgical soap, and alcohol gel before entry and take his hemodialysis. Protocol per patients before the triage. Patients get in the clinic for treatment. By protocol, all patients must hand wash and get new masks every hemo shift. Seen an assistance form and goes to hemodialysis clinic without staying in the waiting room. We close the waiting room so they go directly from triage to hemodialysis to wash their hands and to make the social distance, which is really important between them, staff, and every machine is really well secured. Of course, every machine has a process of disinfection, of cleans, and everything by protocol. Every new patient, we as patient, as this is very important, when there is a new patient or recent hospitalized patient because he went for another situation to the hospital and get in the hospital, for example, by another reason to, as many countries in the world, the infection of the vascular access is one of the most important reasons because the patient get in the hospital, or if the family community history of COVID-19 positive, get in IELTS room that is prepared for that purpose. At this moment, we just have one patient here in Guatemala City that is IELTS in one particular unit. The other patients in Guatemala City or Quetzaltenango that are positive, we think in the whole hemodialysis population are almost 25, 30 patients that are COVID positive in this moment. So they are get in the hospital, and in the hospital they receive the hemodialysis. But in terms of IELTS patients, we just have one patient here in Guatemala City that is using one particular unit just for himself. The staff use equipment for patients that are IELTS is N95 mask, surgical cap, coat, goggle lens, mask with visor shoes. And when we refer patients to Sentinel Hospital, of course, symptomatic patient with fever, respiratory distress from the street, we send to the, in his own transportation to the Sentinel Hospital. In the Sentinel Hospital, the protocol, they take care by protocol, and patient is or was in relationship with suspicious case and quarantine or insanity court. For example, if his community is in sanitary court, or the patient was in relationship with some suspicious case or positive case, of course, this patient cannot go to the unit we send to the Sentinel Hospital, and by protocol, they take care by the infectious disease program and internal medicine disease program and take care of the patient. Or if the patient is hospitalized, the hemo machine and staff and his treat patients go directly to the bed to make the treatment. So the patient that get in the hospital, he stay in the aisle COVID area. The machines go directly to the bed of the patient with the technician, with the full equipment, and perform the treatment over there. In conclusion, Guatemala has a tremendous CKD public problem because of CKD traditional and not traditional reasons. It's well recognized that Mesoamerican nephropathy is an epidemic CKD in southern Guatemala. We don't have any doubt about that. Maybe we don't have report many data, but we are agree that the same situation that's going on in Bajo Lempa, El Salvador, in Chinandega, in Nicaragua, and in Guanacaste, in Costa Rica, and in Veracruz, in Mexico, is the same situation that's going on here in Guatemala. The lack of prevention, early detection, and late referral to nephrologists still to be a problem. This is really important, of course, but the good news is that we are growing in nephrology residence program, nephrology services, and renal replacement therapy for the population. We are working in prevention, we are working in develop and increase the transplantation rate, and we try to develop new, young, and strong, and very smart nephrologists that had the idea from the prevention, the detection, the treatment, and the transplantation as nephrology as a holistic part of the science that try to do the best, particularly in two particular groups, in traditional and in non-traditional disease. In conclusion, in terms of management of suspect and positive COVID cases in southern Guatemala, our hemodialysis clinics are doing an outstanding job. The correct follow-up of protocols is the right way to an early detection and referral of the potential COVID-19 cases in hemodialysis units. It's really important to maintain the quality of dialysis to minimize the risk of metabolic, electrolytical, or overload complications. I want to say thank you very much. Those are the nephrologists that are taking care of the southern coast in Guatemala, particularly my friend Julito Silva, who give me the most of the data, Dr. Wendy Pivaral, who is take care of the unit in Escuintla, Jose Antonio Martinez, who is in take care of the units in Retaluleu, and this is our nephrology staff residence program from year 12 to year 19, that was the last year. So by your attention, muchas gracias. Thank you very much. I am so happy to take some questions if you have at this moment to open the panel for the discussion, and go back to you, Jenny, and Marvin for the discussion. Thank you very much.
Thank you, Vicente, for this beautiful presentation, and also for giving us an idea how is the situation in Panama about the COVID-19 pandemic there, and also how many patients are affected by COVID. CKD patients are affected by COVID in the country. And thank you as well of Nishanta and Sushi for being part of this webinar. There are two questions that have been posted during your conference. There is one from Javier. He's asking, he wants to know if there is evidence of viral shedding in peritoneal dialysis from COVID CKD patients?
Sorry, I didn't get the question properly.
Hmm?
Repeat the question, please.
Is there any evidence of viral shedding in peritoneal dialysis from COVID CKD patients, with CKD patients?
No, not at the moment in the Sri Lanka.
Vicente? Do you have any comment, Vicente or Sushi?
Yeah, I mean, I think that's a really good question. I think we're still waiting data on it. At the moment, everything that a dialysis person touches is being treated as potentially infectious with a dialysis fluid in patients who are getting continuous dialysis, for example, is being treated as infectious, as is the PD. But I mean, I would be reassured that many patients who have COVID-19 don't really have a huge viral load in their blood, and therefore should not have a huge chance of having it in their peritoneal fluid. So the infectious risk could be low, but at the moment we don't have definitive proof on it.
Jenny, do you have any other question?
Well, I would say
Actually, sorry, Dr. Randa Low, put in the chat some evidence that there is an ILD virus in the peritoneal fluid. So this is really important, no? In terms that if you would try to do it, peritoneal dialysis, which suggests that it's a good choice for treat the patients in ICU, because remember, it's not just lacking of ventilators, also lacking of dialysis machines that we need. For example, here in Guatemala, we have just in the Social Security a hospital. We're running the general hospital. We have more than 8 patients that are requiring, not in ICU, but they are chronic hemodialysis patients that get inside the hospital, and the equipment go directly to the bed of the patient. So we need to use many machines and technicians just for one patient over there. So the suggestion is that PD can we use because it's physiological, but remember we cannot use in the prono patients that are ventilated. It's not easy for that. And the virus, yes, is IL from the peritoneal fluid.
Okay, I don't see any other additional questions. I had one, and please feel free to write your questions. And if anyone wants to write questions in Spanish, that is fine.
Ramon,
there is one from Ramon.
Thank you.
Ramon, yeah.
I want to open this for discussion because I saw in the audience many nephrologists that are taking care of hemodialysis. I'm not sure about there is data published about reuse. Actually, it's a controversial. The reuse in general is controversial. I don't think it's a really good idea to, if you are using reuse in your unit, of course you continue doing that. But if you want to change from non-reuse to reuse, I think is not a good moment. It's, for example, if you want to continue open your transplantation program at this moment and your hospital is a COVID facility, is not a good idea. So my suggestion is not to move from non-reuse to reuse. And if you are using in your unit because it's your politic and you believe in that practice, my suggestion is to continue using that. But I want to hear about, for example, Manuel Cerdas or Randall or Regulo Valdez is in the audience also, Regina Sosa. They are really people with experience in that. So I want to, if you guys agree with me to open the mic for them, so maybe we can do a discussion in this and other topics. Regulo, please.
If there are any of the nephrologists that are seeing patients and want to comment, that would be fine.
Hello, this is Regulo Valdez from Panama. I totally agree with Vicente. Definitely, it's not a good idea to reuse right now. In the transplantation comment is different because it depends on how actually your country is behaving the cases. Now in Panama, we have a clear decrease in the number of ICU patients with COVID. So maybe now is a good time to restart the transplantation program because we have a lot of patients waiting for transplant and we have several donors that had been lost during this long period of quarantine.
Ramon wants to comment as well.
Yes, thank you, Marvin. I would like to add to stress out the relevance of this finding that Randall shared in the chat, in the discussion, because most of the time our patients are assisted by a family member of someone else from the family or of his inner circle, and they need assistance for the peritoneal dialysis procedure at home, at least. So if we can find traces of the virus in the liquid, we would have to insist or double the education and the measures that we usually or normally tell and instruct our patients and the family members.
Thank you to both of you. Are there any more comments on that? Okay, if so, go ahead and raise your hand in the chat. Otherwise, Javier Estrada from Costa Rica asks, CKDu in epidemic zones has a larger death toll than COVID-19. Why is CKDu getting less awareness? Do you think it's because it is a disease of the poor? And I suppose that's directed to any three.
Yeah, of course. But I think that this comment gives us the opportunity to make some other comments, of course. This COVID pandemic gives us the opportunity to see exactly how are our health system programs in every country. No? It's collapsing. No? So this is not the moment to try to correct the health system. But what's going on in the southern part of Guatemala, in Mesoamerica and Ethiopia, is the same situation in the poorest people, but it's not because they are poor itself, it's because what we call the healthy determinants of the poverty, which is not just the poorest, it's also the malnutrition, it's also the lack of access to the health system, the low body weight when they born, this is really important. So, but one of the most important things is that we don't have the data, what's going on in our countries, exactly. We need to know exactly what's going on. Because not all the population in the coast develop CKD. So maybe there are many other factors, not just heat stroke or maybe plaguicides, but also there is a third factor which includes this context, which is the real context to develop this disease. Maybe genetics, maybe lack access to the health system, maybe the poverty, of course, the malnutrition and everything. So in terms of COVID, the problem is the same. We don't have the data. The government tells us every day different numbers, every day different people die. But on the other side, the economical, powerful people want to go back to the industry. So the government is in a pressure between the health and the economy. So this, I think, is not enough argument to see that the people in the South are forgotten because they are poor. It's a whole system that is collapsed, involve rich, poor, young, old people, and we are not agreed that because of one virus, we need to reform in this moment the health system of Central America, Mexico, and the Caribbean. It's just my comment.
I think we had the opportunity right now to call the attention about the CKD epidemic in Central America. And that is why last year we organized the third Mesoamerican Workshop, where NIH, WHO, and other institutions were involved. And they were working with us very close, developing the everything. And also we almost finishing the final report from the workshop. Bonnie is here in the webinar, and she is sharing with all of us the next fund grant opportunity that is will be opening by NIH in NIDK for CKD. There are three possible scenario or funding opportunity. One is for field side, and the second one is a scientific consortium analysis data for analysis data, and the last one is the renal core funding. So every year, I think we are opening more the discussion around this topic. We will continue working very hard to increase the engagement and the visibility that that CKDu is a very important problem in Central America, and also in Sri Lanka and India. That this is a great opportunity, and we need to explore this grant opportunity and see we want to apply for a grant, for this grant. Is somebody else had any additional question?
Hey, Marvin, this is Bonnie. I would just add that I added to the chat the notices of intent to publish. So there's the 3 specific notices there. And then I also earlier just put a link related to NIH support for COVID-19 specific research, which is separate from the notices specific to CKDu. But thank you very much for this webinar. It's been very informative.
Thank you, Bonnie. And thank you to everybody for joining to this webinar. And we hope that you enjoy and learn a lot from these 2 great speakers. And we will be organizing our next webinar soon. It is going to be about Mesoamerican nephropathy and the histopathology finding from 3 different areas: India, Sri Lanka, and Central America. The speaker will be Dr. Julia Wilstrom. And also we have a list of possible webinars that we will be organizing in the coming months. Thank you to everybody, and good night.
Good night. Thank you, everyone.
Goodbye, everybody.